Everyone. My name is Dorr&Samal. I'm a primary care physician and researcher at Brigham and Women's Hospital in Boston and assistant professor at Harvard Medical School.
And I'm David Dorr, the Chief Research Information Officer and a professor of informatics and internal medicine at Oregon Health and Science University. We are going to talk to you today about health information technology in helping people with multiple chronic conditions as they manage their health and well being. As we know, people with multiple chronic conditions are especially prone to harm from lack of coordination and communication. The burden of their care is a lot um, to manage and handle and can lead to worse health outcomes. Health information technology is one potential set of solutions that can bring together data, information, and knowledge and facilitate communication to help people with multiple chronic conditions optimize their overall health. However, they also bring some risk of adding complexity, of fragmentation, perhaps even of ethical concerns, as well as burden on care teams and even people with health multiple chronic conditions, and could be challenging for people to use. Our paper will discuss the role of health information technology in helping people with MCCs. We need from you to elicit gaps and solutions that you know about so that we can advance this paper and really help guide the future research in this area.
So, those of you that are familiar with the NIDDK eCare Plan work group and the ongoing project around that will recognize Betsy Johnson, the patient persona that was created for that exercise and has kind of taken on a life of her own. The story of this patient is that she's 60 years old and has type 2 diabetes as well as congestive heart failure. And she also has progressive chronic kidney disease. Her EGFR, estimated glomerular filtration rate, has dropped below 30. She's currently unemployed and she lives in Springfield, Illinois. We have a little bit of background about her life. She's a retired school teacher, and her husband passed away a few years ago, and she lives with her daughter. She also has a son living in a different city. And so, there's some more details here that you can read through, but I really like to talk about this patient persona to kind of help all of us to sympathize and conceptualize the challenges that patients face when they have multiple chronic conditions, and the entire care team, caregivers, and families face. And so I really like the way that this patient persona was kind of fleshed out, thinking about what is Betsy thinking about? She doesn't know what to do for different pieces of her puzzle. What different conditions have different solutions for her, and she doesn't really know what's the most important or what the doctors want her to do, what she can do, and who is she supposed to talk to when she has questions. I mean, these are all common things that I hear from my patients all the time. And as a primary care physician, I'm so happy to be able to help. But I know there's so many people that need so much more help than we, the healthcare providers, can provide in our current system. So we really want to kind of organize this huge topic of health information technology for multiple chronic conditions into 3 domains, and also ask you to be thinking about 2 cross-cutting topics as we're speaking in this video, and then we can have a hopefully very productive conversation in the live meeting. So we've broken this down as the first bullet point: care planning and care coordination. They mean slightly different things. We're going to talk about that a little bit. Second bullet point: patient or person and family self-management, and also in that, patient-reported outcomes, patient-generated health data. Third bullet point, we're kind of grouping together algorithmic clinical decision support for providers and patients, predictive modeling, artificial intelligence, and we'll talk a little bit about risk stratification as part of that as well. So those are the 3 domains. The 2 cross-cutting topics that we really want people to be thinking about and bringing up in every piece of this is issues around equity or inequity, and the concept of complexity and how that intersects with each of these domains.
Thank you, Lipika. So this slide I created for a set of engineers to understand the complexity of care coordination and trying to do care planning for people like Betsy who have multiple chronic conditions. And the conceptualization diagram here really focuses on her interaction, sort of information flow and interaction in these lines with her primary care team, her daughter, who's often her caregiver, with specialists, and a person like her will see in excess of 12 specialists a year, as well as in touching at the bottom all the elements of her care plan, which will involve things like medication, shown with the little pharmacy symbol there, as well as activity and diet and all these other things for daily living. And we can see that really in usual care, there's no coordination of this. Everybody's sort of making suggestions over different times, and it becomes sort of a palimpsest of different um, activities without a clear coordination and without a clear, understandable, action-oriented care plan. Next slide. With the e-care plan effort that was described, as Lipika said, from NIDDK and the CKD, AHRQ has actually taken this and we're implementing at OHSU as part of a effort with RTI to an e-care plan for multiple chronic conditions to really bring this data together, have it in a curated set, and to really help think about what's really important in care planning and care coordination. By bringing the information together, health information technology can be good at that, as well as to really reflect the voice of the person in terms of having goals and preferences, in terms of having understandable information here. So there's a lot of information. HIT can help us prioritize and summarize this in sort of care planning efforts. And as it changes through different coordination activities, provide it to the different teams overall. And you can see on the left here, there's practitioner goals, and on the right, there's patient goals. And really, this kind of health information technology can facilitate conversations that can really improve this care planning effort and keep everybody on the same page so things are much more coordinated. This has to be, of course, in the context of the care teams that are involved with her. And this is one of the things that's available, is actually to gather all that information together from the different electronic health record systems and different health information technology so that it's in one spot for the person to know who they should ask about their particular concerns. And so this really represents a good example of all the potential pros of the positive parts of health information technology for care planning and for managing coordination. And Lipika will talk a little bit about some of the concerns or ongoing gaps.
Yes, and one of the things that, thank you so much for watching this video in advance of the meeting. And one of the things we're trying to do is give pros and cons for each of the domains or each of the examples. And that's to stimulate the audience to think about gaps and ways the AHRQ can help to fill these gaps going forward. So, of course, I was part of this project and it's near and dear to my heart, but I will raise some cons, and I think they're all very, very well recognized. The idea here is for a lot of different people with different roles and different priorities to use the same set of information and have that be the same information that the patient can view as well. However, everyone is going to have sort of different needs from this, and they'll need to touch it at different time points and change it. And without, I think the word conversation was just mentioned, without conversation, interpersonal communication, the health IT could potentially become a stumbling block. Information that's out of date or not filled out can actually, become more confusing for people, for the patient or other people in the care team. In addition, there's the concept of negotiating responsibility and sharing accountability. And without ways to really to do that kind of in an interpersonal way, the health IT really is not going to help and could potentially make things even more confusing or complicated. And, kind of, it's funny here, you do see a couple of 2015s and you might think of ways to say, okay, so is that recent enough information? Does that need to be somehow flagged? Who's supposed to update that? You can imagine as a patient, some of these things might be disturbing. Oh, maybe my care team doesn't realize that I've actually lost the weight and my target weight is now 160 and so on. And so you can kind of see how patient input is very important, and having everyone on the same page is not as simple as just having a technology tool to do that. And just longitudinality and understanding how to synthesize information that in a way that's intuitive for everyone who's involved, including patients who have low health literacy or numeracy, is very important as well. So that kind of leads right into what we titled as patient self-management. Also, I think person self-management is an appropriate way to phrase that. And so, we have obviously a lot of tools available that are technological for patients. And, we also recognize that most of what is happening in the patient's life is happening outside of the healthcare system. And the things that really affect outcomes for all of these chronic conditions are things that happen outside the healthcare system and the patient's day-to-day life. And then, of course, social determinants of health as well figure into this. And so, we do know that there's all these great opportunities for technology. Obviously, all the ways that people can collect data, many, many apps for things like diabetes that people are using on their phones now or laptops, or in a patient portal, which is hosted by a healthcare system. Ways that patients can access education that may be more appropriate for low health literacy or low health numeracy. Ways to educate themselves so that they can take a more active role in shared decision making and be prepared with questions that matter to them, and be prepared to speak about goal setting is listed there, needs, expectations. Ways to share like social support, motivational support with other patient support groups, and then other types of online virtual forums. And I talked a little bit about goal setting. And I think we can talk a little bit about goal-directed treatment as well, and how health IT can really help us healthcare providers to really achieve that. Non-pharmacologic treatments, meaning lifestyle, some of the most impactful things that patients can do are related to diet and exercise. And those are things that we often don't have time in just a clinic visit to really coach patients through. But, with virtual platforms, patients are getting a lot of help with those things. And then also ways to monitor and follow up that might be automated, may have escalation, and so on. So there's, these are kind of the functionalities, but of course you can think about the types of technologies we're talking about, and you can think about automatic monitoring of blood pressure, heart rate, sleep quality, and all of these types of things that are possible even with just a smartphone nowadays.
Yeah, and so there's a lot of promise and some examples here. The cons in patient self-management are, first of all, access to these components. Really, we're asking people to have access to some kind of smartphone or the internet, which is not possible for all patients, and also not understandable for all patients. So we sort of put a burden on them in terms of technology understanding here, and really these tools need to be very understandable to a wide range of people. But in terms of access, actually, on the plus side, we are seeing a lot more people with access, but there's still a digital divide there. For use, that's the second part. Really, there's this interesting issue where people don't use these tools consistently. There are many self-management or sort of lifestyle behavioral applications out there, but only a fraction of people who download them will use them consistently in a way that's sort of helpful. And then if that doesn't happen, then what happens to the sort of recommendation or conversation around that, if there's missing information or it's not used consistently? And then sort of related to that is sort of the benefit that can come from this really does require a sort of engagement in this regard. And really, the techniques to disseminate and use these successfully need to be engaging to help people to overcome that natural barrier to like taking on a new habit, right? So, patient self-management through health information technology tools are sort of a new habit when we're already asking them to do so much.
Absolutely. And you touched on one of the cross-cutting topics there with equity. And I think complexity is another one that we could really bring in here, because, it's one thing. I do have a patient who has multiple chronic conditions who's very technologically oriented. And he does really gravitate to the diabetes apps, but I haven't really seen him doing anything with applications for his congestive heart failure, and other chronic conditions. And so, and it really, it's kind of mind boggling to imagine someone using a number of different apps for multiple chronic conditions.
Yeah.
Okay. And so we are kind of using this as a little bit of a wastebasket term, but we decided to group together algorithmic, clinical decision support, artificial intelligence, risk stratification, just sort of into one large bucket. And so I'll go ahead and let Dave start out with kind of the pros about all of these approaches, and I'll add a couple of cons.
Yeah, so we see a lot of excitement around the use of health information technology to really help people with their many health-related issues. But in multiple chronic conditions, there's really some amazing things that we potentially could do. One is that if we look at each condition individually, there are many potential tasks and approaches, but they don't sort of roll together always to really identify who's at highest risk now and who should we be paying attention to in terms of really focusing our health team's efforts, maybe providing more resources through team-based care for them. And algorithms can really help us do that by predicting risks or of outcomes that are very important overall. And so there's been a lot of effort in this, and it's actually something that health information technology is now used increasingly for and is part of large policy. As well, there can be some really helpful components for learning systems that really try to understand what might be most important to look at now or next, that gathers information together and allows it to be prioritized, as well as helping people to incorporate quickly into summaries and conversations, where we are in terms of trajectories of different illnesses, or if we are sort of at risk of becoming frail, then actually the way these algorithms work can help inform those discussions about, for instance, advanced care planning or really changing the focus of care. They can also identify, bring together information as we're working on a project for high blood pressure control, bring together both the current control and medications, but also adverse events that a patient may be having, so we can sort of focus our therapeutic index for patients and maximize it. So there's a lot of excitement about this, and especially we can sort of get much more nuanced structured data by applying these same algorithms to large scale narrative text or to images or other information, and sort of act on it more quickly in this sort of prioritization and summarization.
Yes, and then some of the cons, I mean, I think, quite obviously, if you're thinking about risk stratification and you have a certain outcome that you're focused on, depending on what outcome you choose, that could worsen inequity. So if you're really just thinking about preventing readmissions, and you're sort of focusing on the highest risk patients for readmissions, you might be spending a little bit less time focusing on patients who need help in other ways. And that's just, that's kind of a question of deciding what's the most important outcome to your organization. And if you have scarce resources, you do need a way to align those resources with the population needs. And then the other piece of it, which I think we're all becoming more and more aware of, is the bias that's introduced into clinical care by predictive modeling or other types of modeling that has biased data. So whether it has a selection bias, and so certain patients aren't represented, for example, we've been applying cardiovascular risk prediction models to patients in our routine clinical care and primary care for a very long time. But the argument could be made that those scores were not necessarily as inclusive as they should have been to different people of different backgrounds or genders. And so these are, of course, things that we're all aware of and thinking about, but very important to understand the double-edged sword of using health IT to push things out and making it easier for people to use the tools, but also what exactly are you introducing into clinical care in terms of inequity or bias?
And this really focuses our cross-cutting issues, and we've mentioned these already, but this article that was really discussed at length, I think, in the media and at probably many of your institutions by Dr. Obermeyer, really highlighted that this actually happens and can hurt, um, can really impair our ability to care for especially vulnerable populations. Here, what you see is they took an extant algorithm that was used to allocate resources for the people they thought were going to need the most resources in terms of having future risks of utilization and costs, like hospitalizations are very expensive, and so therefore we should try and prevent them by keeping people healthier. It's a common thing in population management, and the more chronic conditions you have, often the more risk you have. However, what they found is that here the Black population was sort of underrepresented despite the fact that they had much higher risk from their individual conditions like hypertension or diabetes severity, and yet they were even a little lower than the white population in terms of being selected for a program where they would get more resources. And it turns out this is because if you use utilization, as an outcome, it requires access to care, and they actually had worse access to care. And so that's why, as Lipika said, that's very important. In addition, we talked about complexity. We're really HIT can really add layers to workflow, and there's a lot of evidence accumulating that it can lead to burnout amongst healthcare teams without careful thought about how it fits into workflow and how it can be sort of streamline these often sort of complex workflows for clinical care. So we're going to sort of move to the discussion now. We thought we'd sort of highlight a little bit of a layer of some challenges that we've sort of thought of. You have others, I think, but this may help stimulate the discussion. So what we've seen is, for people with multiple chronic conditions, that we can improve summarization. So rather than going through the chart or trying to manage all these different papers, we can bring that data together, summarize it, and we can provide it at different levels. We can transform the data into looser or rougher granularity or more fine granularity when it's needed, meaning, we can say diabetes, or we can say diabetes with complication, depending on the audience. So we can adapt it. However, that does require a lot of thought and care, and I don't think we've sort of solved that challenge yet. The second, which is related to that, is simplification. So we can also sort of look at health literacy or address it by sort of providing different consumer health vocabularies or different approaches, by keeping it at the sort of right level for people to get the most understanding from it. We also can help prioritize. So we can, there's so much information, maybe some is older and newer. We can use that kind of prioritization. We can also use HIT to run logic on who said what, and if it's sort of a patient-driven, very highly rated goal, for instance, we could bring that to the forefront more and sort of rearrange our screens, and then we could use sort of algorithms for that prioritization for populations and individuals to tailor our care. We also, however, need to continue to think about adjudication. So one of the big problems here is judging what information, especially if it's sort of duplicated or might be incorrect, which we see in a lot of electronic health record data. It's over time. How do we sort of decide which is the right piece of data to show from different teams or groups, and how do we resolve those issues, especially with the voice of the person who might say, hey, this is wrong, how does that work? Because that's a very important thing we often hear. And then finally, and most importantly, health information technology should drive action. It should help in decision making. It should help people understand more about their health concerns and really enable them to be healthier overall, as well as facilitating communication about what they'd like to do with their care team. So all of these really, we don't see solved necessarily through health information technology, and may help you to sort of think about what the gaps are generally. So thank you for listening, and we'll start our conversation.
Thanks so much for watching the video, and we'll see you in the meeting.